Okay, welcome back. We made it to the final segment of the final class on depression and bipolar disorder. All right, so yes, this is a drugs in the brain class, but it's important to mention non-drug treatments. If you can treat something without perhaps permanently altering your brain with rebalancing your neurotransmitter receptor systems and things like that, well, maybe that's a good thing. So it's always important to talk about drug-free approaches to treating depression, and there are a number of them out there. So there's some behavioral approaches, changing behavior. The leading one, and it's fairly effective, is cognitive behavioral therapy, or CBT. And essentially it's helping you change your thought patterns and physical habits so that you can better treat the mental and emotional issues that are associated with depression yourself, so that you can develop your own coping strategies yourself. We'll talk about that in the next slide. Another one that's a behavioral approach is sleep deprivation. I mentioned this a little bit in the last on Tuesday or last week or last Tuesday, is that how sleep disturbances, especially REM sleep or dream sleep, is a core symptom of depression. But it suggests that maybe something about sleep causes depression. And indeed, in a subset of patients, if you sleep deprive them, their depression can actually relieve itself to a degree. It doesn't work for all patients. In many patients, it can actually, or some patients, it can produce mania. So that's not something you want. So that only seems to work in a subset of patients. One hypothesis as to why sleep deprivation might work also goes back down to these AMPA receptors and glutamate and ultimately BDNF, in that we think that one function of sleep might be to reduce the overall glutamate levels in your brain. So when you have a full day of doing things, of learning things, of experiencing things, your brain is super active. You have all those neurons releasing glutamate. And if you have too much excitability in your brain and your neurons, that can be bad. It can actually cause what we call excitotoxic damage. And so one function of sleep may be to generally clean up and reduce the glutamate levels and reduce overall levels of neural excitability in the brain. Well, let's just say, but there is a connection as well with glutamate release and brain-derived neurotrophic production. So let's just say your brain is just not good at being at triggering BDNF production. If you can increase the glutamate level somehow, in this case by sleep deprivation because you're not cleaning it up anymore, then that could trigger more BDNF production. And so that's one theory as to why sleep restriction might be helpful for a subset of depressed patients. And something similar might be going on for ketamine, as I just mentioned, because that might be increasing glutamate, which increases BDNF. And it might also be something going on with ECT might increase glutamate, although it might not increase BDNF. So there's some confusion there, but we'll get to that in a moment. Okay, first I just want to mention what cognitive behavioral therapy is, in case you haven't heard. So you work with a therapist in cognitive behavioral therapy who has been trained to help you as a patient kind of do some self-identification, kind of identify your ongoing thought patterns and your emotional states so that you can sense them before they kind of spiral down into a truly negative pit of despair. So you can actually catch them early on to catch the spiraling cycle, and then adopt these adaptive behavioral strategies, coping strategies, skills that help you then push through them and get beyond those negative thoughts and bad habits. So you're learning a bunch of cool, helpful strategies and tricks after also learning how to quickly identify in your mind when you're starting on the path of, let's say, negative self-thought and things like that. So it helps train yourself to trigger your own strategies to cope with depression. All right. It should be noted that cognitive behavioral therapy is definitely very different than traditional psychotherapy, or even if you go way back to like Freudian psychoanalysis, but it's different than traditional psychotherapy in that it's not trying to identify the deep underlying, maybe unconscious drives that are driving your depression CBT says, well, that's not really that important. All that really matters is the here and now. What is going on, and what are your thoughts that you're having on a day-to-day basis? How do we identify them when they come up, and how do you then immediately do something to deal with them instead of trying to dig deep into, let's say, the unconscious drives, which they say maybe is not as important. What is important is that you deal with your current thought stream. All right, so that's CBT in a nutshell. All right, switching to something completely different is electroconvulsive therapy, and it is what it says. You are actually electrocuting your brain in electroconvulsive therapy. As let's say, what would you call, medieval as that might sound, it can actually be utterly life-saving in a number of conditions, especially when you have severe depression and borderline suicidal depression. You need a trick, you need some sort of treatment that can be effectively instantaneous, because that person is at a loss of losing their life. You only do it in severe cases, though, because it can lead to significant memory loss and persistent confusion. What's interesting to me at least, is that electroconvulsive therapy, or at least the rationale behind it, was discovered over 100 years ago, where doctors realized that patients who had an epileptic seizure had improved mood afterwards. And initially, they would do this in patients who had depressed mood or had other psychiatric disorders. They would induce seizures in patients with an insulin injection, which, if you get too much insulin, it can cause seizures. So insulin-induced seizures were actually a treatment for some psychiatric disorders for a while. Not anymore, because that's super dangerous. But believe it or not, electrostimulation is much, much safer. And in general, it's not as crazy as you might think. You're not going to have somebody just wiggling all over the place and freaking out. It's delivered when the person is under general anesthesia. So they usually put, like you see in the plot down to the lower right, they put something in your mouth, so when you're zapping the brain, that the muscles don't contract and break your teeth, or hurt your jaw. So that's why he has that, or she has that thing in her mouth over there. So that's how it's done, and it's really fast. You can do it in less than an hour, and just like ketamine, a patient can feel instantaneous relief, which is amazing. All right. Which is important because, again, if they were going to be on a treatment of SSRIs, that could take weeks and weeks. Yeah, and as I was saying, your brain is zapped literally when you're under anesthesia. And just like ketamine too, you may require multiple treatments over like every number of weeks or every month or so. You might need a booster treatment. So it's not just a one shot and it's over. And it's pretty darn effective in these treatment-resistant patients, around the same level that ketamine is. It's around 70% effective. Sadly, of course, is for those 30%. Even so, though, this is much higher than the effectiveness of SSRIs for these patients. Okay, now I've done pretty much all I'm going to do about depression, but now let's switch to bipolar disorder. So bipolar disorder is in this chapter because it's an affective disorder. It affects mood, and it also has half of it is depression, regular depression, like we've already talked about, which is treated with all the medications I've already discussed, the depressive part. But it also has this manic component, and you cycle between these manic and depressive phases. So what is mania in itself? So mania is this kind of feeling of being maybe on top of the world. You're kind of bursting with energy, of racing thoughts. You feel you can do anything. Sometimes in another form of mania, it might actually also include agitation or irritability. But it's also this elevated energy that you have. You have racing thoughts again. And so these are the kind of general features of mania. And then it cycles down to depression. All right. Now with DSM-5 to be essentially diagnosed as having some form of mania, you need to have 3 of the following 5 symptoms. Inflated self-esteem, which again, on a day-to-day basis, many people have, maybe have inflated self-esteem. Distracted, decreased need for sleep, and you don't feel tired. Increased goal-directed activity, and excessive involvement in activities with potential for painful consequences. And I was trying to think, okay, well, what's that? I don't know, maybe skydiving or juggling snakes or something like that. So yeah, don't do stuff like that, I guess. But if you have 3 of the 5, then you may be a candidate for mania. I mean, I think many of us are distracted. Many of us go through periods of increased and decreased goal-directed activity. So it seems like these criteria would categorize many of us. But I think one of the canonical features, which isn't really as described as well here, is that for mania, when it comes to bipolar disorder, is it also occurs in the context of ups and downs. You have these periods of hyper self-esteem followed by falling into a pit of despair and then back up again. So you have these fluctuations where you get these things up and down. Okay. So going back to bipolar itself, so you need this cycling between the depressive and mania symptoms. There are 2 general flavors or classes of bipolar disorder. You have bipolar 1 and bipolar 2. Bipolar 1 has more intense, high euphoric, kind of euphoria, elation-like mania in it, and classic depression. Whereas bipolar 2, the mania isn't quite as high and generally maybe doesn't have the elation component. And I'll go through these in a second. But it also has the depression. So here are the 2 types again. As I mentioned before, bipolar 1, you get this elation, disinhibition. You'll feel you can do anything. You kind of say things maybe you shouldn't. But the depression might not be quite as severe as the next class of bipolar. I mean, not as terrible. But bipolar 2 is you get major depressive episodes, so it gets a little worse than in bipolar 1. But your mania isn't quite as high. You don't get the elation. You're just maybe more irritable, but you still have a lot of energy. Your thoughts are racing, but you're not in this kind of feeling great about yourself kind of feeling. It's a different type of mania, and they call it hypomania, meaning it's a little bit below mania. It's still mania, but it's a little below mania. The plot on the right here is a nice little summary I found on the web that kind of shows us the general features of the manic and depressive phases of bipolar disorder. So yes, you can see in the speech that you might have a little disinhibition going on there. You might say things that are vulgar, poor judgment, punning. I don't really know why that would come in there, but that's interesting. Mood, you can have this irritable or even elevated mood, depends if you're maybe in the bipolar 1 or bipolar 2 state. And then depressive is pretty much all the canonical features of classic depression. Insomnia, decreased appetite or increased depending on who you are. You might have worthlessness, guilt, hopelessness. So the classic depressive symptoms there. So let's compare them. Bipolar is much more rare relative to depression. It's maybe in around 1% of the population, and there's no difference in men and women. It's not more prevalent in women or men. And the age of onset's around 20 to 30, so it's a similar age of onset as depression. Whereas in depression, yeah, it's about 16 times more prevalent. And in their lifetime, about 16% of us will experience some clinically defined bout of depression, and it is more prevalent in women. It's almost twice as prevalent in women. So that's just to compare these 2 affective disorders. Treating it. So yes, I already mentioned antidepressants are used to treat it, but the antidepressants don't help with the mania phase. So at the mania phase, lithium, and we'll talk a bit about that in the section on schizophrenia, but lithium carbonate specifically is used as a very effective medication for treating the mania. So it can eliminate those manic episodes without causing depression or making them tired, which is often consequence of some other antipsychotic medications and things like that. So lithium has been an effective treatment, and it's like one of the most common elements in the earth, and so it's not hard to get. So it's relatively inexpensive, pretty common. Yeah, it's also very effective at reducing suicide too in bipolar patients. All right. Then I want to go ahead and also mention another treatment that's for the mania component of bipolar, and that's valproate, or valproic acid is another word for it, or Depakote. Actually, I used that years ago when I was doing studies on autism, because there's some evidence that if you take valproate, if you're a mother in the first trimester, then your children have a much higher risk of developing a form of autism. And I was studying this in rats when I was working in San Diego, so from years ago. And so valproate, we were using it as a way of investigating developmental disorders in the womb. So I don't do that anymore, but that was an interesting angle of study that I was involved in. All right, so that was an aside, but valproate is this anticonvulsive drug. It's taken for a very good reason, in that it reduces seizures in people who have epilepsy. And so it can also actually be helpful for treating like the very intense high level of mania that somebody in the bipolar manic phase is in. And so we don't know how it works exactly, other than probably involves changing calcium release and increasing GABA, GABA is important because GABA is the inhibitory transmitter in the brain, and that might be key for reducing seizures. And so we're fairly sure that GABA is involved, but people don't really know too much about the mechanisms of which valproic acid works. But the main point here is that it works to reduce the manic phase of manic depressive disorder, and that it's also an anti-epileptic or anticonvulsant drug. And as I suggested before too, given my research years in San Diego, it's teratogenic. Teratogenic means that it screws up development in the womb. And so it can mess up how your brain actually forms. And so it can be risky if anybody is pregnant. And so you got to be careful. If you have epilepsy and you're taking valproate, you might not want to be taking it during that first trimester, or if you're trying to get pregnant. All right. Okay, well, on that, that is the end of the bipolar and depression segment of the class. So have a great weekend, and then I'll see you next week for schizophrenia, the final segment of the Drugs in the Brain course. Again, please feel free to send me any questions. We can talk on the phone, we can talk on Zoom or whatever. Again, have a great weekend and find a way to deal with self-isolation in a positive way. All right, have a great weekend.